Hey everybody, welcome to the Med List. I'm really excited about the episode today, Donna, and I think kind of getting into some personal stories right off the bat. I've got to give her a shout out. So my cousin Tina, amongst some other family members, but primarily Tina, she put a book together, and it is of my grandma and papa, and this is them when they went over to Germany. This is where they met after World War II. Grandma was pulled away, and her story is one we'll have to go over another day. But Tina did a whole kind of life breakdown in pictures. And the quote inside of it is from my grandfather, and it's one of my favorites. He says that my grandma found out that he had a sweet tooth, and she nurtured that as best as she was able. And all of my life, like as a little boy, grandma was able to cook for your soul. She feeding you was the way that she loved you. It was a beautiful thing. And so when thinking about food and thinking about talking to Robert, I think just a really, really special opportunity for us to be able to talk about something that feels very intimate, for a lot of us in our lives. And there's a lot of emotional connections, but we don't always think about it with medicine, Donna. Hey, how about you?
Yeah, well, definitely. We all love food, right? And there are just some very special traditional dishes and things such as that. But when I'm teaching, I'm also often talking about Mediterranean diet with my students. And then I say, do you know what this means? And I make them read about the Mediterranean diet and then go, oh, not realizing all the different pieces of that pyramid. So can't wait to learn about our guest and what he's doing with food as medicine.
Oh man, that's so fantastic. And what better time of year than we're all trying to be on these new diets, to learn out what actually is good for us. And without further ado, I'll bring Robert to stage.
Hello.
Hello, welcome. And so happy to have Dr. Robert Graham with us today. And not only is he a physician, but also a chef, and just love that combination. He is one of less than 50 doctor chefs worldwide. So a little bit more about our guest is Dr. Graham is Harvard-trained physician, board certified in both internal and integrative medicine, a public health scientist, health service researcher, TED speaker, food activist, and chef. So what a wonderful mix. And Dr. Graham believes medicine needs a fresh start. Together with his wife, they founded Fresh Medicine and Fresh MedU, an online self-care university. And I want to share what Fresh is. Fresh is an acronym for the 5 ingredients in their recipe to health: food, relaxation, exercise, sleep, and happiness. I think that's an amazing mix. So I love that acronym. And just wanted to share one more thing about Dr. Graham. He is the chief health officer for a medically tailored meal company called Performance Kitchen. And I can't wait to hear more about this because I know we're going to touch quite a bit on this today. So thank you so much for being with us. This has just been, you've been somebody I've been trying to connect with, and so glad we finally did.
Yeah, me too. Donna, I know you reached out to me a while ago, but it felt like the world really needed to hear this at the beginning of the year. So the time is perfect.
I agree. So I would love for you to share more about yourself and just your road to becoming a physician and then a chef thereafter. So just please share your story.
I'll try to keep it. I'm calling you guys from New York City, the Big Apple. I'll try to keep this in a New York minute or so. I'll give about 3 or 4 minutes because it's always awkward to talk about, how great I am. I like when people introduce me and tell people how great I am instead of me taking the stage and say, hey, listen, this guy's an awesome guy. Well, let's start off by saying that I like to say that I'm the son of a farmer and the son of an immigrant. My dad was a farmer on a little family farm. He was born on a prairie in Washington State. He moved to a town of 600 people, the big city, and then got drafted into the Vietnam War and found himself in New York City. My mother is from El Salvador, and she comes from a lineage, only recently found that there's a lineage of healers, traditional folk healers within our community. And as a child in New York City, she was a flight attendant, and she found herself in New York City, in Jackson Heights at a crash pad. My dad, like I said, came to New York City as a veteran, as a recruit for the Vietnam War, and had to find a place to live because the barracks at that time on Governor's Island were just packed. And so he was given $100 to find a place in New York City. Remember, he was born on a prairie, found himself in New York City, and said, "You have $100. You got to figure out where to live." And so they both met up and lived in Jackson Heights, New York, which is the most culturally diverse neighborhood in the world.
Wow.
160 languages spoken, but 70 countries are represented. And what do they bring with them? They bring with them their foods, their cultures, and their traditions, particularly their beliefs around health and well-being. And here we are, 3 docs talking, 2 pharmacists, 1 MD. We are seen as sort of the alternative to what they believe can bring us health and well-being. You know, the last thing you want to do is take a drug and or see a doctor, right? So it's sort of the flip of the paradigm I was raised with. In that ethnic community, I grew up with people from all over the world. So the world came to me. I didn't have to travel the world. And again, those early experiences and going to Bobby Kling's house, who's Indian, and I was getting I put oil on my head, and I said, what's this? And realizing that it's part of the Ayurvedic traditional Indian healing systems. Brian Lee was Chinese. We used to get acupressure points in our ears. But what was fascinating throughout my entire sort of upbringing is that every time you went to a home, to your point, Kevin, people's love language is often food, particularly when you think about when you're ill. There's usually someone comes over, right, with something that's therapeutic, regardless of whatever culture, race, ethnicity you are. There's usually this healing potion driven by the love they put into by making it at home. And then if you're really, really sick, then you go to the hospital and then you get the drugs, right? And so when I wanted to be a doctor, I realized that this beauty, this magic of health and well-being was absent in medicine. And through my early training in medical school, I had the fortune of starting one of the very first electives in integrative or complementary alternative medicine. I had the blessing, once I decided to become a doctor, to do integrative and complementary and integrative medicine. I was one of the very first fellows back in 2003 to go to Harvard Medical School to study this evolving field. At that point in my career, there was really 2 spots available, one at Harvard and one in Arizona with Andrew Weil. But I knew that if I wanted to sort of push the envelope on what true healing is, I would have to go to someplace with sort of the academic creds, because everybody always says, and still says to this day, well, where's the science? Where's the science? And be honest with you, there's a lot of science out there. And we don't really truly appreciate the ancient wisdom blended with modern medicine. And that's what I try to do in my own practice called Fresh Medicine. As you said, you know, fresh medicine, fresh health needs a new start. I'm sorry, medicine is a fresh start, you know, and I think I like to say that medicine needs more health and care. And that's really what drives us. We need more health and care in healthcare and less medicine, because I think that's what people are wanting in today's world. And so that sort of frame of reference. Once I graduated from my fellowship, I did get a master's in public health from the Harvard School of Public Health, focusing on clinical epidemiology. So I am a reformed clinical researcher. I was lonely in my office, you know, writing papers, doing data analysis, and I went back to be a practicing physician. And I went through the ranks of academic medicine within academic institutions to this title of associate professor of medicine. And I ran program director of internal medicine residency programs. And that's where I had the opportunity to really put my imprint on this evolving field called culinary medicine, the intersection between the culinary arts and the science of medicine. And for about 6-7 years, we took doctors out of a hospital and into a kitchen to teach them the principles of healthy eating through the lens of cooking. And I think that's one thing that sort of has been taken away from our educational system. Home economics. I learned more in home economics about how to be a living, surviving person than I did in any other training. And so sort of bringing that home economics, caring for thyself first, into medical education. And then roughly about 7 years into doing that, I decided that I loved hanging out with chefs. No offense to docs, but chefs are a lot more fun and they feed you a lot better food. And so I became a chef. and went to culinary school nights and weekends. And proud to say that I've been a chef now for roughly 8 years, and the world has finally caught up to this notion that food has an important role to play in healthcare, and in my opinion, has a food-first approach. We should be changing our lifestyle, particularly how we eat, what we eat, and why we eat, and then explore the role of medications in this sort of holistic approach. And then lastly, about 6 years ago, a company, a healthy food company, at that point it was called Luvo. The CEO approached me at a conference and said, "Hey, would you like to work with us?" And I said, "Well, that'd be kind of cool. I've never heard of a doctor working for a food company, a healthy food company." And I sort of decided to work with them. And now it's been 6 years. We pivoted from what they call a CPG, consumer packaged good, like you would go to the store and buy something that's healthy, to a medically tailored meal company, which I like to say are meals that are designed by RDs, created by chefs, and prescribed by doctors. And that space, I know we'll talk about that in a little bit, but that space is, I think, going to be the missing ingredient in, I think, optimal health and well-being within the delivery of a conventional medical reimbursed system. So, and then last but not least, because you mentioned it, Donna, is that when I decided to leave academia and start my own practice, it was really a proof of concept. I wanted to believe what everything I learned and how to integrate this ancient wisdom into modern medicine through the lens of evidence-based medicine. And that's how fresh medicine started. We do exactly what every single doctor does. We do two things differently. We take our time, right? Because health takes time. We listen, and we approach the patient's intake by first not asking what's wrong with them, but really looking at those 5 ingredients: food, relaxation, exercise, sleep, and happiness. And we have found that once we address those 5 ingredients or 5 pillars, medicine is of less or no need if they're willing to be an active participant in their health journey. Health is a verb. It doesn't happen to you. You have to pursue it, and you have to work at it.
Wow. There was so much packed in that information. I've been taking notes feverishly here. And I just, so many things that you said, talking about the fresh start and thinking about those 5 areas of, like you're saying, the food, relaxation, exercise, sleep, and happiness. And I'm thinking, as we're going through this, you also said more health and care and less medicine. And you are just singing our same song here, in that we're trying to reduce medicines, especially inappropriate and unnecessary medicines, because so often, as you know, people end up on a med and it stays with them indefinitely. And many of our older adults are thinking, "Oh, I'm on this for life." And they don't necessarily have to be. And it's really hard to change that conversation with people. So so one of the things I'm interested in is being able to integrate all of this, and then having people accept this. Like, I sometimes, as a pharmacist, have difficulty trying to get folks to think about their meds a little differently. How are you getting people to think about their health differently when we are so far away from that culture that you talked about growing up in your neighborhood? Of, you kind of held off, you didn't necessarily run to a physician or try to take a medicine. You were trying, maybe some other things first, and having that family care first, and then needing a doctor when necessary. So how do you get people to accept that?
Yeah, so this is probably grammatically not a word, but we like to use it. I like to use it. It's called pre-education, and pre-education is sort of a setting the stage, right, for that clinical encounter. Let me tell you a little quick story here. So I use a lot of food analogies, so I apologize, but it's delicious. Okay. The way I say this is that many people spend more time choosing where they're going to go out to dinner, right, on a Friday night than they do on how to pick a doctor. Right. Many people just, literally blindly choose their doctor and think that that's it. And I like to say that there is a lot of well, there's a standard of care that we all have to do, but how we do it and why we do it can be radically different, right? And one thing to the audience here, if you're not happy, change your doctor, right? You're not stuck with him or her for the rest of your life. Also, I think part of that pre-education realizes that at our offices, we will put food first, right? And so we have found that people really gravitate to that notion, because I think just morally, less ethically, but morally, and I think intuitively, people feel that they would want to get off these pills. I don't think anyone really is dying to take a pill in the morning, right?
Mhm.
Let alone, as you all know, 70% of Americans take one medication, and about 20% of people take more than 5 medications a day, right? And obviously, as illnesses increases, as aging increases, usually the amount of pills increase. And
Mhm.
we have found that there are a bunch of people in our practice that really see it differently. I think there's 3 cohorts in our practice. One is that this sort of, and you're hearing it now more than ever, right? Today is inauguration day, right? It's a new term with new ideas. But one of the things that sort of resonated with me during this campaign was that MAHA movement, right? I think there is this sense now, more than ever, on both sides of the aisle, right, that we need a fresh start at healthcare, and we really have to look at it as a way of taking ownership over our own health, for good or for bad. We can think of this person's bad, that agency is bad. I don't think there's any bad people in healthcare, really. I don't think there's any sort of evil empire there wanting us all to get sick so that we can get more medications and hospitalize people more. But this is where we are today. And I think people are just waking up to the fact that there should be, or there is potentially, a different way. But what we fail to realize is that there are not enough doctors, and I think that take the time, partly because of the system that we're driven by, right, to allow that conversation to unfold. So that goes back to the point I was trying to make, the pre-education. So one of the things we've done is really sort of make a name for ourselves that we are going to put food first. We are going to be working with the other doctors and pharmacists to de-escalate you off prescription medication or de-prescribing. Because again, you're right, Donna. Just because you had something one time doesn't mean that you have it for the rest of your life. And a lot of this happens upon discharge from a hospital, right? You're initiated these drugs, and to be honest with you, no one tells you stop taking them, right? And that whole refill button, it's really easy now, especially with EMRs. Just click refill, but never have the conversation. And I think it is our responsibility as clinicians, but also I think patients are sort of waking up to the fact that there's something not right about this. And so I think that's what we're working with. We're working with that sort of community of people out there that just are second guessing the need for these medications. But you have to support them in that transition. And that's where I think a real holistic approach really is important.
Yeah, that's great.
I feel like the personal overlap, Donna, between Robert and I is really wild. Having the family that has a farming background, coming from Washington, having the chef piece. So I have one of my many favorite uncles. My uncle Paul was a chef in Central Washington for a decent portion of his career. And so thinking about those connections there, Robert, the one thing that I'm fascinated in from my kind of roots in Native American health and some of the things I'm doing in the technology space, there's 2 stories I'm going to try to weave together and ask you kind of your thoughts on what society's going to do, what you're going to do with it. Is OpenAI recently, one of these large LLM kind of systems, ChatGPT for those folks that are out there. There are several others, but they've put forward kind of a system that's based on a wellness factor. Like, how do we improve our health longevity? In other words, how do we stay healthier and live longer at a healthier stage? So they're putting models together that are focused on that. A lot of excitement around it. And there's a lot of other companies that have done that, a lot of other influencers that live in that space of saying, if you do these things, you'll live a healthier life. Usually they don't involve medicine at all in the typical context. The other story, Robert, real quickly. So I'm Yakima native. I grew up on the reservation, and talking to another colleague of mine that's on the Spokane reservation. We're talking about just the state of healthcare in Native American health in general, right? tons of comorbidities, especially those that are due to metabolic syndromes, diabetes in particular. And as we were going down that road, he said to me, Kevin, I think it's really interesting the technology world you're working in and the medicine stuff you want to talk about, but I can't get fresh produce within my town. I literally have to drive 45 minutes to an hour away to get access, in general.
Yep.
So I think that the excitement is there, right?
Yep.
From individuals. They're looking for it, they're hunting for it. You can look at the waves on social media, what they're trying to look for. And it's not coming to people with PharmDs and MDs at the end of their names, right?
Yeah.
And the need to be able to have the access, is paramount. So my kind of pivoting question back to you is, if we know that patients would go, I can see Dr. Graham, and he's going to tell me about the foods I can cook to be able to feel better and live a better life, as opposed to going to Dr. Smith, and he's going to tell me about the 7 different pills I've got to take, and that he wants me to go and see X, Y, and Z other specialists. It seems like a no-brainer, right?
Yeah.
In general, which one would society prefer? So what are the current barriers and maybe the opportunities for us to be able to make that shift?
Yeah, so great question. Listen, I love the personalizations of I think storytelling is the way sort of to drive this home. By the way, my dad is from Oakville, Washington, which is in central Washington.
Nice.
Yeah, and so actually, I believe that our registered dietitian with Performance Kitchen lives in Yakima.
Oh, no way.
Yeah,
Wow.
my family's my dad sort of jokes around, we're cowboys and Indians. So my dad, yeah, my half of my uncles married Chehalis Indian tribe.
Yeah.
And so
We're
that's where
probably related, Robert, is probably
yeah. Yeah, I love to talk about the Indian Health Service, and I think a lot of work is happening right now. If we had this conversation 4 or 5 years ago, nothing was happening, but I think now there's a pivotal point, partly because of policies that's driven. The power of a pen is a very powerful movement. We have a lot of people that want this sort of healthcare. I'm going to try to answer both questions into one. We have a lot of people that want this change, but yet the policies that drive it are counterintuitive.
Mhm.
And some of the work that's happening, probably in the last, say, 3 months, 4 months, is sort of having this discussion come up front. Again, both parties, right? The other important factor to consider is I got to shout out someone, because I spent so much time in the food space. There is a food hero of mine that I had the pleasure of sharing a stage with. His name is Chef Sherman. Do you know this guy?
We haven't met him yet, but he'll be on the show next.
Yeah, so he's native. He's born. He was raised in the oh man, it's gonna lose. It's where the pipeline, the big controversial pipeline was happening in
North Dakota, South Dakota.
Yeah, in the Midwest there. I forgot the name of it, but he was born on our reservation. He has a 3-star Michelin restaurant now in Minnesota, driven, okay, by taking agency and ownership back. And this is what I'm trying to build here. Take agency and ownership back, exploring your cultures and your roots. That's why my TED Talk was called Back to My Roots, by the way, because I really think that there is something in us, right, that really aligns with that connection. And he's been able to sort of highlight and make native food a 3-star Michelin chef. And through that platform, his voice is so magnified. And I love it. I absolutely love it. And if you don't know, learn about him. If you have the opportunity to reach out to him, get him on your podcast, because it's such a powerful message. The other part is the barrier is how healthcare is delivered, right? The way it is paid for, right, is driven by volume, right? Traditional ancient Asian texts from the Yellow Emperor says that the doctor shouldn't be paid his full bounty until he has healed the person.
Wow.
Right. And so I come with that idea that, I haven't done my job if I haven't fixed it. This weekend, we had a leak in our sink, and we called the guy on call to come in. I live in an apartment in Manhattan. The guy came and did a half-ass job. Guess what happened? The next day, I had to call another guy to come in, right? And that's not the goal. The goal is not to keep the sink half leaking or us half healthy, right? The goal is really working with the patient to make them healthy and whole again. And so that's the real thing that has to change. We have to change how healthcare is reimbursed. And one of the things that I'm really proud about is that once I left academia and started Fresh Medicine, I never thought I was going to come back to a large health system to sort of do this, because again, there's no way to do it. I'm proud to say, as of the last, say, year and 3 months, I was recruited by a large health system called Catholic Health out here on Long Island to launch the first ever integrative and functional medicine department within a hospital that is covered by insurance with a food first approach. And so it is insurance covered, but also by the vision of our CEO and leadership supporting this. We know that if we pay a little bit more upfront for the covered lives that we serve, we're going to get the return on the back end of decreased health utilization, decreased escalation of care, less prescription medications, and overall a healthier society. And I think that's where we sort of have to prove these models out. But I can say this, after reflecting after 25 years of doing this is the first time in my career that I can say that there appears to be, let's call it that, there appears to be the desire from both patients and providers for a different approach.
Wow.
That's great.
That's massive.
I definitely want to touch on the I'm sorry, you had mentioned the medically tailored food, excuse me. And can you share with us, I'm assuming you're incorporating that into this practice that you're talking about at Catholic Health. So if you could just share what that actually means and how do we do this?
Yeah, for sure. So a couple of things there. So at Fresh Medicine, right, again, goes back to the pre-education, right? And that's what sort of differentiators in today's world, right? We all sort of do the same things, right? How we do it is a little different. So what we've done is on Fresh Medicine, really build out a platform that talks about this food first approach. Okay, I still deal drugs. I joke around. I'm still a drug dealer. I still got prescriptions. I still have. In that transition, you need medications, and for certain things that are medically necessary, you need them. And so I don't want to have this sort of notion that I'm doing alternative medicines and giving patients herbs and supplements and food when they're having an MI. Right? No, you need medications. It's again, do we need them all the time? And so one of the things that we do at Fresh Medicine is this pre-education. But really important, we also have the opportunity through our online school called Fresh Med U to support you in your health journey when you're not in front of me. Right? And so when you go home and you start thinking about, how am I eating? How am I relaxing? How am I doing these things? You can always go onto our school, and we have some paid content. We have some free content. I encourage everyone to take the free class. It gives you a quick snapshot of why these are so important in your recipe to health. Okay. And that's important in supporting the patient once they leave the office. Right? How many times have you guys gone to your doctor's office and you say, oh man, I wish I could have asked them that question. Or I wish I would have talked about this. And so now here you can actually go online and actually interact with one of our health coaches too, if you have any questions. So again, you're never alone in this journey. The other way we do it is that, again, the pre-education is that you're going to see the doctor. Okay, you're going to get your history and physical with a focus on these 5 ingredients, but immediately, right, you're going to be set up. Again, we do an insurance verification with a registered dietitian. Okay, they are the masters of this knowledge. To your point, I'm going to get back to the point about AI. I think AI has an important role to play this because the personalization, particularly of nutrition, is going to be very key. Data inputting your preferences, data inputting your data, your biological data, laboratory data, current medications, preferences on food. You will be able to design the personalized nutrition meal plan for you using AI. So I think AI, artificial intelligence, is a really important factor that we have to consider as part of our toolbox. But equally important, real intelligence is still trumps. Okay? I don't want to say that this world is going to all AI. I think RI, real intelligence, human intelligence, is really important too. That's why this high tech, high touch is really a theme in my practice. So you're going to get fed, you're going to get a registered dietitian, and then we work with you to explore the opportunities to work with a health coach. We have sort of different plans, if your insurance doesn't cover, that is a sliding scale based upon your economic need. right? And so
Yeah.
it's the Robin Hood, take from the greedy to give to the needy, right? It's not from the rich to the poor, but greedy to the needy. But in our practice and at Catholic Health, that's the sort of the model. You will get your assessment, a formal medical assessment through the lens of internal medicine, integrative medicine, and functional medicine, but then sort of be paired up with a healthcare team that focuses on a food first approach. Once we identify, and you guys all know this, that most chronic conditions in America have a dietary strategy for its support. The DASH diet, right? The MIND diet, the low FODMAP diet. These are all diets that have been proven efficacy for a chronic disease. We just don't prescribe it.
Yep.
And this is what we do in our healthcare system, in our healthcare practice. So the registered dietitian with the doctor sets a medical diet for you, a therapeutic diet for a short amount of time to reverse or help prevent or mitigate the effects of this disease. DASH diet is classic. Donna, to your point, they're all grounded, right, on the Mediterranean dietary principles. But the problem is that we, as my mom from El Salvador, she goes, Mediterranean, I'm a Salvadorian. Why would I eat Mediterranean? So using the foundational principles of the Mediterranean diet through the lens of your culture and ethnicity is what is sort of my specialty in the culinary arts.
Yeah.
The African culture through the lens of Mediterranean diet,
Right.
Asian culture through the lens of Mediterranean diet. So then what we do, just really quick about Performance Kitchen, using the foundations of the Mediterranean diet, we've designed around 70 different meals that, again, racially and ethnically and culturally inspired for chronic conditions. But as you know, the secret sauce here is the Mediterranean principle. If you do the Mediterranean principle, your rates of Alzheimer's, heart disease, cardiovascular disease, diabetes, so many things can be mitigated by adopting a more Mediterranean diet through the lens of your own culture. And we provide these meals right to your home if paid by your insurance, right? And that's where the big problem lies in today is that it is a covered benefit, but in some insurance companies. And we can talk about that too if you want.
Yeah, very interesting. I just want to go back to what you're saying about the Mediterranean diet and the culture shifts that you need to do. So much like you, where I am in central Massachusetts and at a pharmacy school, we have students from all over the world who actually come and to be pharmacists. And I have to say, similarly, the world comes to Massachusetts, right? But just like New York and various places you've been. So, anyways, so part of the conversation with my students is, could you do this diet, or what would you shift in your culture in order to make that work? So we definitely have that conversation, and some will say, there's no way I would eat some of these things, but I would eat this instead. So I love that you're adapting it and
I think chefs have a huge role. I think, and part of the reason why I love doing what I do, particularly in the culinary space, is I think if you think about your chef, right, in your community, they are the ones that bring the Thai food, the flavors to you. They bring the Indian food to you. If we just lived within our little bubble, we'd probably eating the same stuff all over America. But it really are the chefs, through their travels and their experiences, have brought these foods to us. And Kevin, also, right, the elevation of the native chef, right, in today's world, right, we don't hear about, except for maybe Chef Sherman there, Sean Sherman, his name is. And I think, thinking about colonialism a little bit, it was really the Native American diet was free of many ills of what makes us sick today, right? It did not have refined sugars, right? It didn't have a lot of the quote unquote junk food or the highly ultra processed foods that the westernization of our culture has unfortunately brought with us. And it's happening worldwide too. I travel the world, and same thing happens to the beautiful traditional culture of Japan. Once westernization of our food system comes in, I call it the SAD diet, right? Standard American diet. Wherever the standard American diet goes, 20 years later, the standard American diseases follow. So it's the SAD diet followed by the SAD diseases. And it's simple. It's linear. And we have to sort of mitigate those effects.
I think that's super helpful, Robert, in so many ways. And I think there's a lot of deeper connection to it. I mean, I think that preparing food in general, like the therapy of not only going and talking to a nutritionist and an MD/clinical team about what your meals are going to be is a different approach that a lot of people aren't used to. But the fact that we only say that, like the DASH diet or any of the other diets, I'm just showing a screen right now on the Mediterranean diet so that folks don't think it's too complicated. Very, simple. It goes in more detail on what these particular foods are with each one of these individual sections, but breaks it down into a very whole food based diet, getting appropriate leafy green vegetables and fats. But going back to my point there, the act of making food, Robert, us making our own food, when it comes to the mental health crisis that we're going through today, there's some very interesting pieces that I think we can pull in together there. So really I'm segueing into kind of the about them section is I truly understand that we're trying to say, hey, great, let's get people better diets because they've got these disease states. And if we give them the diet rather than the drug, we can hopefully get them to where they want to be and have additional benefits. I'm curious on some of the other things you've brought in that people may not initially think of, like, what are the problems in mental health that the approach that Robert and his team are pulling in is addressing, utilizing these modalities? And two, which is a major kind of growing issue, is things like irritable bowel syndrome, the ever increasing number of people that are having allergies, food related allergies, et cetera, et cetera. Are you seeing some of those individuals? Well, this makes too much sense. I need a specialist in food just as much as I need a specialist in medicine.
Yeah, great point here. So a couple of things. Here I am. Here I go. You ready? So I've just told everyone that food is medicine, but no one has the skill, time, or money to cook. Right? So how do we sort of do this? And that's where I think what we offer at Performance Kitchen, the medically tailored meals company, goes and really has an impact. And so instead of thinking about, going to the grocery store, affording the groceries, unpacking them, listen, it's a pain. I do it all the time, but it's time, skill, and money, right? Mm-hmm. So the idea of a medically tailored meal, if I can explain that a little bit, right? So these are meals designed by registered dietitians for chronic diseases. You mentioned IBS. You mentioned mental health issues. There are diets that have been shown to sort of mitigate some of the effects. IBS, it's low FODMAP, right? Or a specific carbohydrate diet. You have to explore that, particularly with what type of IBS you have. Yeah. And then using technology, right? I think what we do in our offices too, we do food sensitivity panels, we do hormone testing, we do inflammatory blood markers, but we also do gut testing. I've been doing gut testing, microbiome testing for 17 years. Yes, we don't truly understand, but we're learning a lot more of the role of our gut microbiome, not only on our digestion, but on our metabolisms, on our immune system, on our mental health. 95% of neurotransmitters are made in our gut. If your gut is unhealthy, your brains are going to be unhealthy. It's bi-directional. And so I think together with the movement of food as medicine, people wanting a different approach with the science of gut health, through the lens, again, through a functional integrative approach, is really, I think, going to help answer these tricky questions that patients are suffering from. But just going back a little bit, time, skill, and money. So at Performance Kitchen, what we do is have gone into the lab, identify foods, make them, again, Mediterranean inspired, culturally tasty, right? So foods that you want to eat, not have to eat, but also designed for specific health conditions. And so there, you don't have to think about buying and shopping, preparing, cleaning. You just eat this. And you eat this for a therapeutic amount of time, just like drugs are intended to be used for, right? Mm-hmm. And then reevaluate the need, or transition them to now the second part of this conversation is medically tailored groceries or produce prescriptions, right? Mm-hmm. With, again, the foundational knowledge of an RD nutritionist, but I would argue also at the same time, give people the tools that they need in the culinary education. Yes. So it is somewhat complex, but we're sort of trying to build out this model. If you're familiar with the food as medicine pyramid by the government, but also by Tufts, it starts, the tip of the spear is a medically tailored meal, transitioning to produce prescription boxes. These are boxes of produce, right, that are healthy for your health condition. And the beauty of what's happening today, I can tell you this. We have 20 side contracts with insurers, payers, that will pay for this intervention called food as medicine in the form of either a medically tailored meal, produce prescription, registered dietitians, and I'm still fighting for culinary education to be brought back into it. Because if you're giving a head of broccoli or cauliflower raw, what do you do with it? Right. And so I love the fact giving patients healthy produce, but without teaching them how to cook it, you're really sort of leading them halfway there.
Yeah. Amazing.
I can't agree with that more. I think that the piece that you're drawing in there that I think for the audience to be able to listen to is the fact that we now are kind of broaching the subject of payment, right, in general. So folks are always thinking, well, my grocery bills are not getting any cheaper. If I could buy my wife a new diamond ring and afford eggs, I could do both, Robert, but the eggs are going to have to be the priority today, and they're just about that expensive. So I think that when it comes to affording foods and having your insurance be part of it, give me your thoughts here, Robert.
Sure.
You talked about the model, right? And the way we deliver it and the way that we've kind of constructed it on a volume-based scale. And so I thought, well, the way Robert's talking right now, I'm guessing he has a value-based, background with Catholic Health, and that's really the initiatives that they have, or he's looking at a direct primary care model of saying, okay, there's a certain element that we have to be able to pay our doctors to make us healthy. Like that's the end result that we're looking at. So when you're talking about payers becoming involved, get us a little bit more information. Like what do patients know so that they can say, well, can I have my meals paid for by my insurance?
Yeah. So we made it really easy. So a little lessons learned, right? Is that you don't know what you're entitled to if you don't know what your insurance covers. Okay. So one of the first things we do in our private practice, but also Catholic Health, we do sort of a pre-authorization of your benefits, right? By addressing those 5 ingredients, right? I'm going back to a little bit about the mental health issue you brought up earlier. If you ask the patient, do you have time to relax, right? We don't call it stress, right? We thought of the S is sleep, right? We thought about stress, but we like to keep things positive. Stress usually has a negative connotation. So Kevin, how do you find time to relax? Oh, I can't relax. I'm always stressed. And then that opens the door in a very non-judgmental way. If I ask you, Kevin, what's stressing you out? Immediately you're going to be having it. But again, the notion of talking about how do you find time to relax, it's a different sort of approach.
Smart.
Sleep also, right? Sleep, it's compounded by stress. When you're laying alone and the world is falling apart and you're by yourself at night, when the lights are off, that's when the monkey mind starts coming out and starting saying, how am I going to get out of this? What am I going to do tomorrow? How am I going to, so our approach, I think, really non-judgmentally really approaches these very sensitive subjects with our patients. Now, also, one of the things we do is that we do this authorization. And so do you know that you are entitled to 3 massage visits because your insurance company pays for it? Do you know that you are entitled to 7 registered dietitian visits because you do have diabetes? Most people don't know what they have because they never look to know what their insurance covers. I'm not saying all of them, but nowadays we have the ability to do Google or, call one of us to identify this. So here we go. So Performance Kitchen, if you go onto our landing page right now, our website, you will find this thing called the Benefit Locator tool. We have found that about 80% of Medicare Advantage companies throughout the country have some sort of food as medicine benefit. Now, I mentioned to you, medically tailored meals, produce prescriptions, registered dietitians. One of those 3 things, 80% of Medicare Advantage companies cover. Okay? We are fighting, and I'm down in DC. I had the great privilege of being at the White House conference 2 years ago on food, hunger, and nutrition. And we are down in DC, led by your man, my favorite food hero in Massachusetts, McGovern, Senator McGovern, House Representative McGovern, right, on the Medically Tailored Meal Demonstration Act, right? And so what hope will happen in the next sort of year is, with bipartisan support, have Medicare cover food as medicine, in particularly medically tailored meals. Now, Medicaid is the third beast, right? So I've spoken a little about commercials, right? MA plans, commercial plans. To this day, no commercial plans covers food as medicine.
Okay.
MA plans, 20%. Medicare, experimenting demonstration projects throughout the country. The main thing that's happening throughout the country right now are these Medicaid, which are state-run health insurance companies, they have these things called 1115 waivers. The 1115 waivers are waivers because they're an additional funding resources to Medicaid that cover food as medicine. Now, you wouldn't know that, but your health institution should know where they are. You go onto our website, you put in your name, your zip code. We've done the work for you. We will identify plans that cover a medically tailored meal. Okay? Now it's up to you, right? This is what insurance companies fight for all the time, for their star ratings. Why are you going to choose Humana versus United? Why are you going to choose United versus Aetna? It's because what they offer you in addition to the basic healthcare needs. This is what they all want. This is the fight they're all fighting for, increased star ratings, so you get more patients under their plans. What we've done at Performance Kitchen is, again, if we are not a covered vendor with that insurance plan, we will tell you who it is. So we believe, right, in democratizing this. If we are not the provider, but X company is, we will tell you to go with that X company. We feel that it's more important for us to help patients identify who is covering food as medicine for them today, right? Than for us to lock it down. Eventually, we would love for them to come over to us, right? But again, this is the benefit that we're providing patients all over the country on our benefit locator tool on our website. Once you do that, we will do the authorization. We will reach out to your doc to say, hey, Kevin, do you know, Kevin, your patient, Mr. Smith, is requesting a medically tailored meal. All we need is your okay for us to send it to him. And boom, we deliver right to your house meals that are covered by your insurance. Now, the amount, the duration, we know the drug works. We don't have, to your point, we don't know the duration and the dose. Does 1 meal a day work? Does 2 meals a day work? Does 3 meals a day work? Does it work for 3 months? Does it work for 6 months? And I'm not saying we're going to feed the planet for the rest of our lives. The idea there is teach him, right? Yeah. In today's world, where we have limited resources and time and skill, that the beauty of how you can feel on these medically tailored meals can hopefully be that trigger that sparks that change.
It's amazing.
Oh, thanks. Yeah, it's easy. It's easy. It's we did it overnight.
I'm assuming that this is for any age. So I'm thinking all different ages have Medicaid, for example, or be eligible for Medicaid. And then those that, of course, are 65 and older or disabled might have a Medicare Advantage opportunity. So I'm assuming that it's not age driven unless it's just the insurance itself that you have. So are you helping all ages?
Yeah. Yeah. And so, unfortunately, the way you all know this, right? Age is the greatest secret here. Age is the greatest predictor of death, right? So as we get older, we get sicker and we die. Okay. But at the same time, that is usually where most of our healthcare dollars are spent, right? Yes. It's tied, it's very closely tied to social determinants of health, particularly food insecurity, right? And so that is a recipe for failure, right? If you're food insecure, you don't have enough money, and you have many chronic diseases, it is not a good outcome, right? And so what we try to do is help patients identify what is covered. Again, that pre-education, as mentioned before, the pre-authorizations for patients to identify what they're entitled to. And many people out there, Donna, just don't know that their insurance covers medically tailored meals. And I think that, I'm not saying there's a game there, but it feels like there is a game there. And our job is to, again, advocate for our patients, to give them what they've paid for, using what they've already sort of, what they have paid for already. It's a benefit that's entitled to them. And we've put pressure on our society, on our companies, to act on that sort of covered benefit, right? The biggest problem here, honestly, guys, is determining eligibility, right? So we have a lot of patients that log on to our website, and their MA plan doesn't cover. They don't fall within a state that has a Medicaid 1115 waiver, and Medicare is still sort of waiting to do this demonstration project. So it kills me, it pains me, right? That we can say, Donna, thank you so much for reaching out. What we say intentionally, for now, there is no covered benefits in your geographical area, right? But I think we'll get there.
Yeah, absolutely. I'm curious too, like I'm thinking as you're speaking here, I, you talk about these stories, right? And you go and you speak to others and you share your knowledge. And even just Medicare Part D plans for drug coverage can vary dramatically too. So thinking about that and having conversations with various folks about, you know, premiums and deductibles and just the general understanding of health insurances. But what's really interesting is key people who might be the pivot person for people to gain this knowledge from. Are they clued into this? And so while you're speaking, I'm thinking
Yeah.
about two different agencies, and that's the Executive Office of Elder Affairs that are in pretty much every single state in various towns and districts, but also the National Council on Aging. And I'm curious, like, do these organizations know about exactly what you're talking about you, about this um, medically tailored food? It's
Yeah, I know. Yes. So I can speak for New York, okay, and Massachusetts. Okay, is that the Department of Aging is well aware, and they're part of the funders. The way each state has their own sort of way of distributing meals, but I just want to bring back something, okay, because I'm speaking to two pharmacists, and this is sort of how look our pre-work started. The role of the pharmacist is so important, right? Ideally, and by the way, we are I don't know, without clearing with our CEO, I don't want to talk about specifics, but we are working with pharmacists within grocers, right? Because I think that's going to be the magic key there. So
Mhm.
imagine this: you go get your medication. The pharmacist, right, also tells you, hey, by the way, do you know that your insurance covers a medically tailored meal, right? And we have a registered dietitian right here. Or you can go to Performance Kitchen, who is the provider that we've contracted with to get this. So the pharmacist, as you know, you may see a doctor once a year. If you're not controlled, you see him 4 times a year, but you see that pharmacist monthly. If you're in a grocery store, you're in that grocery store weekly.
Mhm.
Drive by there. And I think sort of it's always been this, the pharmacist over there, the doctor over here, the RGD there, the health coach here. And
Right.
I think this movement really can amplify this by using and leveraging the power of the pharmacists, the local pharmacists, which is a trusted source and a trusted brand. I think that, again, similar to chefs, have been a missing link, not only in dispensing drugs, right, but also in providing health and well-being for our populations that we serve. Listen, we're trying to get the word out as much as possible. Unfortunately, the way it works in today's society, right, is that someone has to pay for this. And we've, again, been proud of the fact that we've negotiated with 20 different insurance companies to be a covered benefit. Eventually, I hope will happen was that these experiments called the waivers, the 1115 waivers, become part of Medicaid. And finally, we get this bill that McGovern has sort of put out there. I do believe, going back to the point that this is a very interesting administration, very interesting time, where both parties realizing that there is a bigger epidemic than COVID. There is the epidemic of chronic diseases that's impacting all of us.
Yes.
Yeah, I think from the clinician's perspective, I know, sorry, clinicians listening, you probably think, wow, what happened to us on the med list today? We're really talking patients here, which is great because I think that direct to patient component really empowers patients in lots of ways and lets them know that they can take advantage of the foods they're eating to be able to heal them and give them better lives. But from a clinician standpoint, Robert and Donna, your thoughts on this one too. Is there a tiered approach? So, for example, is there a way for us to go from, I think it's fantastic that Robert and team at these various companies are able to go, we can get you the foods you need, we can tailor those foods, we can get you multiple kind of consults with experts to be able to get that to you. Is there a couple tiers down lower that actually requires more from the individual patient to put effort out, but maybe something we could scale, inside of our systems earlier, inside the system? Robert already mentioned that several insurers are paying for dietitian consults. And I'm very curious to know because I have colleagues that one of them is a pharmacy owner and he has his wife who is a registered dietitian come into the pharmacy and talk to patients every once in a while and talk to them about different foods. They don't have a grocery store, which would be fantastic. And what a
Mm-hmm.
combination of things. And then I have another colleague that worked for a very large grocer, very large grocer, and actually was very close to seeing if that grocer would start doing exactly what Robert was talking about, trying to get them to help patients when they were coming in to select foods that would be best for their long-term health, overall. So is there something that we can have or advocate for our clinicians to say, even if your patient doesn't qualify, it'd be amazing if everybody did. You don't have a patient that's on Medicare Advantage on these particular 80% of plans or 20% of plans, whichever of the two I'm missing, or the Medicaid individuals, they're not in that gap. What can they do?
Donnie, you want to take this? Or is that directed to me? Or
I'll direct it to you. I do, just very briefly, I do know that there are different grocers, as you've been saying, and I do know that they do have R&D type of folks right there in the grocery stores. And I do know that, in fact, there are some grocery stores that actually give free diabetes medications locally, and their pharmacies are located right next to their Whole Food section too. So I do know of some of those grocers kind of working it a little bit, if you will, but not to the point where this is a completely different level.
Yeah, I listen, I think I do envision a day, right, that there becomes a sort of seamless, and that's really for the patient out there. It has to be, you have to be sort of a recipient of this, right? So health is a verb, so that takes action, but the whole process should be supportive. And I think through these sort of demonstration projects like these 1115 waivers, and it still needs to be ironed out how to deliver it. But I believe through our fresh approach, right, peeling back the layers of the onion, on not necessarily on the problem, right, which is the tip of the iceberg. Really, what is the iceberg? All these other things that are affecting that diagnosis at the tip. And oftentimes, if you start approaching our patient and ourselves, really, right, you can't pour from an empty cup, right? Let's face it, pharmacists, nurses, doctors, all of us are overworked, many times underpaid, burnout, depression, suicide is a real big problem in our profession. If we can't do it, who's going to do it, right? So it first starts with us. And thinking about your own, to the patients, thinking about your own sort of fresh pillars. You don't have to eat right every single day, but try to hit one of those pillars every single day. You will get to that point that if you don't eat well, you may not exercise. But if you exercise, you may eat well. And that night you're going to sleep better. And that's going to make you happy. And so oftentimes patients tell me all the time, what is the most important pillar? I really believe that they're all synergistic, right? Because they sort of have a domino effect on each other. And for me, really, it's the power of the community. Happiness is based upon positive psychology, right? Because it's the art and science of well-being. We all want to be healthy. We all want to be well, but we're never given the tools in healthcare, in medicine, to do it, right? We're just typically given a drug to get the numbers down. Really is not what we're all intending to do, right? I know from pharmacists too that I've met and spoken with, the idea is about de-prescribing, de-escalating, and trying to make a healthier patient population that we serve. And so I think patients have an active role, but again, being supported in that journey by your doctor, your dietitian, your health coach, your registered dietitian, your grocer, and your chef, that we're all sort of in this together for your health benefit.
That is super helpful. I think the only big takeaways that I want to kind of share before I pass the torch off to Donna and Robert here is, from the clinician perspective, the one thing that I feel like I've got to advocate for is, we took all the time. I mean, some of us that are this old, there used to be a drug called warfarin that we used to use.
Yeah, I know. I remember.
There's a drug called warfarin we used, and all of us had to memorize all of the green leafy vegetables to avoid. Right. So we didn't have the vitamin K interaction with the warfarin that would then throw off your what are called INRs, which are bleeding rates for that individual drug. So we put a lot of effort in that, clinicians. If we could take that kind of effort and put it into the foods that our patients should be eating, or the things that are beneficial, or to look at what drugs are causing nutrient depletion and how to be able to help them with that, I think that would be a massive win. And Robert's got a lot of fantastic resources here for folks to be able to take advantage of. From the patient side, Robert, I really think that the piece that I love is, let's get to know our benefits, in one way, shape, or form, and use some of these programs to be able to tell us what do they actually offer. Because, even though you might not know how to start doing anything other than chicken nuggets and macaroni and cheese, which, hey, that's, you can survive in college on that for a little bit. But if you don't have an idea of where to start, it's great to be able to have some expert advice. And if part of that expert advice can be paid for on a benefit you're already taking advantage, or you should be taking advantage of through your insurance plan, then by all means, I think that's a great opportunity for society. But I'll pass it off to you guys to finish up our show here.
Yeah. And just another thing too, and thinking about insurances as well as we're talking about this, is even there's exercise benefits too that people might not be taking advantage of. So we're hitting a lot of these pillars here and trying to make that all work. So so yeah, I think that there's much to be explored, and it's important to know what your insurance does cover for sure. Robert, I can't thank you enough for joining us and your many words of wisdom. There's so many things I'd love to recap here, but I just want to make certain that we get your message out as to what's most important to you. And if there's anything that you want to share, that's your ultimate goal for clinicians and for patients at this point, we would love to hear that.
Yeah, for sure. Well, thanks. It's been fun. Also sort of expanding the people you talk to is really important. And I spend a lot of time with doctors and chefs, but it's always good to talk to people within healthcare that are not necessarily my 1-2 punch, right? And so I thank you for inviting me to your platform. I always like to end words of wisdom for your patients and also our colleagues here. It doesn't take a lot to bend the health curve, right? We're on a sick curve right now. It doesn't take a lot. And so if I can sort of end with my prescription, when it comes fresh, okay? When it comes to food, eat more plants. When it comes to relaxation, spend 10 minutes a day. Disconnect. Exercise, 30 minutes a day. Walk 15 minutes in one direction, turn around and walk back 15 minutes. That will compound itself. Sleep, aim to 7 to 8 hours a night. Happiness, surround yourself with people who support you. I think the power of connection is very, very strong. And there are people that will support you and people that will not support you. And, as we get older, we realize who those people are. And we have no time for that. I like to close with this. When it comes to our health, it starts with food. But again, what we truly want in life is to be happy. And I'm so happy to be sharing my experience with all of you. And again, this is sort of building a community of like-minded people for the ultimate good.
Amen.
So much.
Well, thank you so much for your time. Thank you so much for your wisdom. And thank you all for listening and for all your comments that I'm seeing on the side and likes and mentions. It's always very appreciated. You can follow us on YouTube and LinkedIn and Facebook immediately, and then we can grab some things on those other streaming apps later on. But thank you once again, Robert, for your time. And everybody have a wonderful night, and hopefully you eat some really good food.
And stay fresh, right?
Stay fresh. That's right.